Hello everyone, and welcome to today's webinar, Promoting SBIRT, or Screening, Brief Intervention, and Referral to Treatment in an Interprofessional Setting with Vulnerable Populations. I'm Tracy McPherson, and I will be your webinar moderator today. I'm a Senior Research Scientist in the Public Health Department at NORC at the University of Chicago. I also lead the Brief Intervention Group, Big Initiative, and lead the SBIRT work at NORC in collaboration with IRETA, the National SBIRT ATTC. So I would just encourage you, you're welcome to use my contact information that you see here to contact me. If you have any questions about SBIRT or this webinar or any of the work that we do, I encourage you to reach out. Today's webinar and all of the webinars produced in our series are produced in partnership with the Brief Intervention Group, or the Big Initiative, NORC at the University of Chicago, the SAMHSA-funded National SBIRT ATTC, and today's webinar is in collaboration with CSWE, the Council on Social Work Education, and we are pleased to be able to have Andrea Bediaco with us today. Andrea, would you like to say a couple of words?
Thanks, Tracy. The Council on Social Work Education has been working with a consortium of social work programs across the country to integrate SBIRT education into social work curriculum. We are pleased to be able to collaborate with NORC on this webinar today, and I'll pass the presentation back over to Tracy.
Thank you, Andrea. So this webinar is part of our 2017 SBIRT webinar series. As you can see, we're about halfway into our series, and we are thrilled today to be able to really focus on vulnerable populations. It's something we've been working on over the last couple of years to really try to target in on the application of SBIRT with various populations. You'll also see coming up in May, we're going to look at differences and commonalities of the application of SBIRT in various settings. I think some of the themes of working with vulnerable populations will come through there. So I encourage you to join us in May. And also in June, we are going to be talking more about SBIRT and the application of SBIRT in addressing problem gambling in military populations. So I hope that you will join us. And also, if you notice in our webinar series, we have a couple of webinars focused on intimate partner violence, or IPV. If you are new to us, you haven't seen our newsletter yet, but you will coming up soon. We have put together a mini-series on IPV and the application of SBIRT working with young women and in other special populations working with women. So there's a mini-series that we've released, and I hope you'll take a look at that. All of these are available on demand, and they actually any webinar series for the last 5 years is available on demand. So please take advantage of that. We also offer the continuing education credits with our on-demand viewing as well. Access to all of the materials for today's webinar is available already on our website. We have a dedicated page to this webinar. You'll find PowerPoint slides and any materials and resources. For example, if our presenters point to a specific resource today and they think that'll be useful to you, we will get that information and place it on the website with the PowerPoint slides. You'll always have one place to go. In addition to that, the on-demand recording, available 24/7, will also be posted there. And there's also going to be a link which will allow you to request a certificate of completion after you've completed today's webinar. Later, at the end of the presentation, we're going to have a Q&A session. And if you're not familiar with the GoToWebinar panel, typically up in the upper right-hand side, there's a questions pane. Now, you're able to go ahead and get your question in. In fact, I'd encourage you to get your questions in early so that we can try to answer as many of them as we possibly can. And we will leave about, I think, probably about 10 minutes at the end. But we encourage you to get those in the queue, and we'll try to take them first come, first serve order. And behind the scenes today is our technical facilitator, Misty Story. If you have any technical questions, of course, you could put those in the questions pane, and she'll be helping you to address those. So now it's my pleasure to be able to introduce our presenters today. Our first presenter is Dr. Molly Everett Davis. And Dr. Davis is an associate professor in the Department of Social Work at George Mason University. She's an experienced social work educator that has been involved in teaching social work students at the undergraduate and graduate level. In addition to her work as a faculty member, she has practice experience in mental health and substance use, and she has served on policy boards that govern mental health service delivery to include substance use disorders. She currently serves as curriculum coordinator on an SBIRT grant received by George Mason University. Dr. Davis has an extensive background in many areas of behavioral health and trauma, to include cultural competency. She currently serves on a team of faculty who manage an interprofessional primary health, behavioral health clinic that serves vulnerable clients and trains nursing, psychology, social work, and other allied health students. So I welcome Dr. Davis. And we have a second presenter with us today. Dr. Shauna Aquavita is an assistant professor at the School of Social Work at the University of Cincinnati. She has a decade of social work experience working with individuals who have been diagnosed with mental health and substance use disorders. She completed a pre-doctorate fellowship in maternal and child health at the University of Maryland, Baltimore, and a postdoctorate at Johns Hopkins University in the Behavioral Pharmacology Research Unit. Her research focuses on substance use disorders, including tobacco use among vulnerable populations, specifically pregnant women. She is also a proponent of interprofessional education and collaboration. So thank you both. Thank you, Dr. Davis and Dr. Aquavita. I'm going to turn it over to Dr. Davis to get us started.
Thank you, Dr. McPherson. We are really excited about the opportunity to engage in discussion on this important topic, and we welcome all of the participants in this webinar. We're really looking forward to not only presenting the information, but also hearing your questions and engaging in discussion around the topic that we think is so important. During this webinar, we will explore the implementation of SBIRT in interprofessional settings, and we will be highlighting those issues that surface from our own experiences. We will also introduce a variety of opportunities and challenges in implementing SBIRT with vulnerable populations, and introduce some different perspectives on how to look at those populations. We will share examples of our efforts to implement SBIRT in several settings with the goal of helping you think about your own setting and the vulnerable populations that you might be serving. Throughout this webinar, we will continue to explore the role of faculty, students, along with our SBIRT grant teams in addressing some of these issues. We're going to start out by looking at the concept of interprofessional collaboration. This is an important concept and one which is getting a lot of attention. But there are some core elements of what we're talking about when we talk about interprofessional collaboration. The definition here on the screen is when multiple health workers from different professional backgrounds work together with patients, families, and communities to deliver the highest quality of care. Now, we all understand that it's more than having individuals from various disciplines work in the same room, because we do that all the time. So we are talking about a quality of interaction that really does support collaboration. And when we think about that, we think about concepts of teamwork. We think about concepts related to community and communication practices. We think about this in regard to values and ethics, and many of these can actually seem to clash until we really figure out that what we're really working for is to provide a high quality service to our clients, and that is what we have in common. So focusing in on the areas of commonalities becomes very important. And then delineating roles and responsibilities. We're going to talk about that as specifically I talk about the MAP clinic experience that we're involved in at George Mason University. And I was really heartened to hear the director of the clinic say to a group of students, when you work with the patients that come in, it doesn't mean that any one particular professional group is the lead. It depends upon the issue. And that really made an impact on students. It was a different message, but it's a very important message. So we think about the patient as being the focal point and not so much our own professional leadership, but we contribute our expertise in a way in which the patient benefits from that. The other term I want to look at is interprofessional education, which I find really very fascinating, having had the opportunity to be involved with, again, our MAP clinic, as well as our SBIRT grant. We really need to, and we have been thinking about, how do we educate students so that they come to appreciate the value of interprofessional collaboration. And the educational process is the best preparation for creating a workforce of individuals who really do value interprofessional collaboration. And so it's important for us to think through, and maybe we even have to think out of the box, about how we can instill these competencies in the training of students. It's very important that faculty buy in. And so once you gather and gain faculty buy-in, then students can see and have opportunities to really understand and embrace the value of interprofessional education. So I think we're in a very important time, and there's a lot of interest in understanding how to do this and how to do this well. And I think that our patients will benefit the most if we can figure out how to work together in an interprofessional context. Now today we're going to share some of our own experiences and insight as we move this discussion forward. So my colleague Shada will now begin to tell you something about the University of Cincinnati.
Thank you so much, Molly. So I just want to give you a background for the University of Cincinnati. We have an academic health center, and that serves as the foundation for training healthcare providers, and it focuses also on education and research. It provides a range of interprofessional training and experiences, and so it consists of 4 different colleges. We have the College of Medicine, Nursing, Pharmacy, and Allied Health Sciences, and that's where the School of Social Work falls into. We are a strong partner for interprofessional education and research within this academic health center. So one example of an interprofessional training program we have at UC is a grant that we received through SAMHSA, and that is our SBIRT grant, and it is a SBIRT interprofessional training program. And our goal is really to train 160 medicine, nursing, pharmacy, and social work students. And we train students through a course which I will discuss shortly. We also train preceptors and field instructors and also health professionals, and this is all within a 3-year period. We also are creating and testing and are going to disseminate some SBIRT curriculum modules on special populations as well. and we are creating an online SBIRT CU course for our UC Medical Center, which is another place where we have students located. So I'll talk about that in a little bit. One thing that we do, though, is that we use community agencies to inform our SBIRT practice. So we really think this is important and valuable to partner with our agencies. Not only do they provide locations for our students to have training, but they are also on the forefront. They are really able to share what is happening, what is going on, and what do we need to be aware of in the community. So some things that we do is that we provide SBIRT trainings to all staff agencies if they need them, and also booster sessions if they want those. We meet with agencies before and after each semester to discuss any concerns, questions, or thoughts about the clinical experiences. We actually bring a lunch as a thank you and to just engage them in conversation and talk about the process for them. We also include them in our board of directors for our grant, and we meet quarterly, and we have 2 representatives from these community agencies. So let me talk about the course that we have for these students that actually provide them with interprofessional experiences as well as an SBIRT experience. So this is a semester-long course, and the first half of the semester is online. And that allows for our students from medicine, nursing, pharmacy, and social work to be able to take care of the education that they need to take care of on their different schedules. Because that's the big challenge for us, is that different people, different schools have different schedules, different breaks, and so we're just trying to figure out when we can all get together. So if we get them to complete the education online, then we meet at least one part of it. We have virtual simulations, and that's the first image as well, and they can complete those online, and it gives them a good background on how to complete SBIRT. Then our midterm exam is a standardized patient experience, and this is actually an interprofessional standardized patient experience where we have 2 students from different professions do screening and brief intervention together. So it's an experience for them to be able to get to know each other and then get to process afterwards with faculty member how that experience went. And then finally, students, after they've completed the midterm exam and successfully passed it, then we allow them to do clinical experiences. And I will be talking about their clinical experiences in a little bit more detail. But this is really where our interprofessional competencies are met. And so the core competencies for IPAC, interprofessional collaboration and practice. Domain 1 is values and ethics for interprofessional practice. Domain 2, roles and responsibilities. Domain 3 is interprofessional communication, and Domain 4 is teams and teamwork. We actually have them experience all of those because they experience values and ethics for interprofessional practice when they are having the standardized patient experience. They are also learning different roles and responsibilities on who is going to do what because they have to work together in the standardized patient experience as well as the clinical experience. And then we have them engage in interprofessional communication because they have to communicate all the time. And then the teams and teamwork, they have to work together in order to be successful. These clinical experiences at these locations, they're generally 3 hours each. We have an orientation to the agency. A staff member provides that. Our faculty member is there too to observe or be a part of whatever SBIRT experience that they have. And then the faculty member processes that experience afterwards. And I'll talk a little bit about that in more detail. So I'd like to pass it back to.
Thank you, Shauna. I'm going to tell you a little bit about George Mason University. We're located on the East Coast and actually we are in the Washington, D.C. metropolitan area. The College of Health and Human Services is where the social work department is located, but you can see that there are representatives from multiple disciplines in our college, which makes it really a great opportunity to have interprofessional interaction, collaboration, and to promote the interprofessional education of the students who are in the college. George Mason also is a recipient of a SAMHSA grant, training grant, and our theme is cultivating SBIRT champions, training all behavioral health and healthcare professionals to ask about substance use. So we have looked at spreading the word about SBIRT and training students and members of the community in using it as an effective tool to identify early substance use risk. Our team has three primary areas written about in our grant. Curriculum infusion, where we're really looking across the curriculum and looking to integrate or infuse content on SBIRT in places where it naturally fits. As we look at social work, for example, and we look at the core elements of SBIRT, there's very much overlap. And so we've looked across our courses to look at where can we infuse this content. This is true for nursing, social work, and psychology, which were the three disciplines that we identified in the grant. In addition to curriculum infusion in the classroom, we're also looking at the infusion into the clinical or the practicum environment as well. And this is being accomplished in a variety of different ways. We are having the opportunity to train field instructors, but we're really excited about a new project where we hope to pilot with an agency the opportunity for students to do their internship there and also have an active opportunity to use SBIRT because the agency staff will also be trained in SBIRT. So we're really excited about that. We have been innovating some models of how do you train. We're specifically very interested in simulation. We're also developing special exercises and other kinds of strategies to train students in SBIRT. And then lastly, we are interested in community engagement. And we are training agency personnel in SBIRT. We have a conference coming up pretty soon that's actually going to be open to the community to receive SBIRT training. I want to talk to you about the program that I'm going to use as an exemplar today. And it is the Mason and Partners, we call it the MAP Clinic. This is a free clinic that serves the uninsured, and it provides an opportunity for our students to engage in interprofessional collaboration and education, and also it represents serving a vulnerable population. And so many of the examples that we're going to be talking about today, I'm going to pull from that because this clinic exemplifies some of the benefits, but also some of the challenges as we really look to serve a vulnerable population. The clinic is interprofessional in nature, and it serves the uninsured, immigrants, and refugees. So most of the patients do not have any documentation. Therefore, there are challenges around how these patients will be served. So this is a nurse-managed clinic, and faculty serve as providers, and students also participate in this clinic on an ongoing basis. as an opportunity to experience working with the patients who come there, and also to learn how to work with them effectively. SBIRT screening has been implemented in the clinic, and we are documenting the encounters with using the screening there as well. The clinic also is using what we call a bridge care model. So it recognizes that there are people in the community who are vulnerable because they do not have insurance, they have no documentation. There are healthcare challenges, and there are a variety of different other issues that make them vulnerable. So the MAP clinic is designed to provide a means for them to have access to health care until they can be linked to a permanent medical solution. So it's a bridge between individuals in the community, primarily immigrants and refugees, who do not have any ability to access medical care, or they only access emergency room care. They come to the MAP clinic and they are served by faculty providers and students until such time, and again, it's a very limited, brief model, until we can get them connected with a more permanent home, medical home. The setting is interprofessional in nature because we have the participation of the disciplines on the side in the delivery of service. And so students and faculty work together, and I can say that it has been a significant learning experience to really engage in understanding other professionals, their values, their patterns of communication, which can be very different. But we try to maintain an open-minded attitude, and we really value what we've been able to create by making sure that we communicate well within the interprofessional context. So our topic today is really looking at vulnerable populations. And so the question here I would ask is, okay, so who are you talking about? Who are they? And I think this is an important, relevant question because generally the vulnerable population will be defined differently depending on where you are and who you choose to place emphasis on. So in the comments that I'm going to make about vulnerable populations, I'm going to keep it broad enough so that you can think about your own area, your own resources, your own communities, and really think about who this vulnerable population is. There is not a universal vulnerable population. So in defining a vulnerable population, there are a number of ways in which this occurs. In the research, we find that sometimes vulnerable populations are defined by biophysical, environmental threats, psychosocial, socio-political circumstances. And so there are a variety of ways in which vulnerable populations are defined. But the key issue here is that vulnerability, is based upon susceptibility of risk to harm. So when you think about your community and you think about who are the most vulnerable for what particular condition, you again will see that it will vary. I want to use the MAP clinic as an example. So in the MAP clinic, we find that the vulnerability is based upon, as one of the factors, their status as being undocumented. This means that they have a very, very limited ability to access services because they don't have Social Security numbers and they don't have the paperwork that supports that. So we see that this is definitely a point of vulnerability for those clients. That may not be true if you're working with individuals who have insurance and they have documentation. So that's just one example. When we look at the population that we serve in the MAP clinic as well, we look at issues around language. Because if you don't speak English, then that means that in order to understand what is going on, you have to access others who can help you understand that, translators, interpreters, whatever. So those are just examples of a special kind of vulnerability that we see because of the kind of service that we are offering with the MAP clinic. It could be very different in your setting. And so it's important to really think about this. But vulnerability and risk factors are very related because both impact the ability for some harm or harmful outcome for the clients that we serve. So again, the point that I'm making is that you will need to define your own vulnerability factors depending on who you are and what kind of program you are offering. Now, these are some common areas of vulnerability that you find in the literature. But one of the things that we're suggesting here is that you consider developing a vulnerability profile. And that will allow you to identify, again, the specific vulnerabilities of the populations that you serve. And the other thing that that does, it allows you to bring some agreement around targeting certain of those vulnerabilities. Most of us could not target all of these. But as we look at our populations, as we look at the organizations, as we look at the settings, which one becomes most relevant? And out of the decisions that you have to make about what can we do within the parameters of our programs, which ones would we make number one? I already identified that as we looked at this with the MAP clinic, we identified immigrant status as definitely one of the major factors that impacts vulnerability. We also mentioned language, and that too becomes particularly relevant. But you might identify poverty, or you might identify homelessness, and so it's whatever the decisions that you make around the vulnerability factors that you're going to address, develop a profile about that, target your effort and your attention towards that, and also use that as a point of bringing together some consensus around some focused efforts to really address the vulnerability factors. The second point I want to make is around data mining. Now, this data mining concept, as I'm using it here, suggests that whatever factors that you choose to consider as a vulnerability factor, that you then have to really do your homework. You have to look at the literature. You have to understand a lot of information about those particular factors. When we look at the data, whether it's data from our program or whether it's research data that you get from the literature, it begins to help us understand more about the vulnerable population. And that's really foundational to be able to think about what adaptations do we need to make in order to address this vulnerable population. For example, on this represents some of the clinic data that we've collected, and we know that this is important and relevant. We know that there are diverse languages. What does that mean? Well, that means that you have to look at the ability of providers to communicate. You have to look at a variety of different other factors that impact our ability to serve patients well. In addition to that, we find that the patients in the clinic have both chronic and acute diagnosis. We also find that in terms of the behavioral health areas, there seem to be 3 primary diagnoses that seems to be relevant across the population: depression, trauma, and anxiety. And you can understand in a population that represents immigrants and refugees how those behavioral health issues become really important. Some of the patients that we serve have just come into America within the last week or 2 weeks or 3 weeks. Many of them have observed traumatic experiences in that journey, such as being raped or seeing others who are killed. And so when they come to the clinic, we find that trauma is a common denominator. Again, that may not be true for your particular program or setting, but it becomes very, very relevant to our setting. Okay, cultural diversity. This is really another part of the data mining process where we really look at and recognize the fact that we serve diverse clients. And this is just a summary of some of the countries of origin. So you can see the diversity represented there. And as you think about targeting cultural diversity, then you can see that it's very important to really think about how do we manage the challenge of multiple languages? How do we create an environment where the differences are respected? How do we understand elements of the cultures of the patients who come to be served? So this is another example of how it's very important to know your own vulnerability factors and then to be strategic in what you do to try to address those issues. So developing a vulnerability profile would suggest that you have to define what is the vulnerable population that we're going to address. Secondly, you need to do the data mining that allows you really to understand those vulnerability factors and to consider, are there ways in which you can address those issues or not? And I find that once you've done that, then as you look at implementing SBIRT, you will find there has to be a connection between those vulnerability factors that you have created or identified, at least in your profile, and how you implement SBIRT. For example, one of the cultural issues that we were able to identify is that very often the Hispanic or Latinas women do not drink at the level, alcohol at the level of their spouses. And so, but by the same token, the research literature, and we also did identify this as well, it's more likely that the male would engage in heavier drinking. So we have to be strategic in thinking about how do we reach this vulnerable population when it could be only the female that is seen in the clinic. So we started to strategize and to think about, okay, so how can we empower the women to go back home and maybe have a conversation with the spouse about alcohol use? What can we put in her hands that might be particularly helpful in moving forward the discussion about whether the substance use is at a risky level? That's just an example of how, again, how you look at the vulnerability factors and then you think about in the implementation of SBIRT, how can you consider both of them and what are the areas of adaptation that will be required in order to accomplish our goals with our patients. And so you can see the last part of that is developing strategies for adaptation, but you really can't do that until you really understand the vulnerabilities and you've thought through and researched as much as you can about them and then look at how SBIRT might impact that in some way. The next slide shows you again some information about immigrants, refugees, and undocumented individuals. And so this is an example, again, too, that when you look at the literature, and if there's data in your community, obviously you want to look at that as well. But we see some things that's very important about these groups if this represents one of your vulnerability factors or several of your vulnerability factors. These have some relationship to your implementation of SBIRT. If trauma is a common denominator in many of your clients, you may find that that impacts your ability to do SBIRT screening. They may not be really engaged in that process because there are other things. We find that when you have patient populations with a lot of trauma and who live in a survival mode, it's very difficult for them to think about maybe not engaging in risky substance use behaviors if those substance use behaviors are really helping with trauma and helping even to survive. I'm just going to summarize here on this slide that, again, we have found information that tells us important information for considering vulnerability. And a lot of this comes from the research. We work a lot with Central Americans, and the research indicates that Central Americans drink less than Mexicans. I found this information. There's not a lot, but there is information that attempts to tease out the substance use patterns by ethnicity. And that is very important as we think about serving those same ethnic groups in a program like the MAP clinic. This slide simply shows that there is a relationship between identifying vulnerable populations and substance use. And the common denominator is risk stratification. So SBIRT looks at risk stratification. And when we develop a vulnerability profile, what we're essentially doing is creating another system of risk stratification based upon the vulnerability factors that we've identified. And that helps us to think about the commonalities and what needs to be addressed. So when I look at the MAP clinic vulnerability profile, we see a variety of different issues. Now, even though these issues represent aspects of factors that impact vulnerability of our patients, again, decisions have to be made about what ones we would prioritize and ones that we would not. So I'm going to turn it over to Shauna now, and she's going to talk about implementing SBIRT with some of these vulnerable populations.
Thank you, Molly. So Molly was going to also review a little bit about the need for shared consensus, and I think this is really important to what we were going to discuss too, in that we really need to take a look at what's going on with the individual. What is their health diagnosis, language, ethnicity, their status and trauma history. So we really need to be careful in regards to that. So we're going to give some specific examples for implementing SBIRT with vulnerable populations. And the first population I would like to discuss is homelessness. We know in the U.S. that approximately 18% of individuals are homeless in the U.S. We also know that substance use disorders have been linked as a contributing factor to homelessness. And so the estimates of substance use disorders among individuals who are homeless are between 30 and 77%, depending on their demographics, and that can be age, race, age, educational level, and ethnicity. So there has been SBIRT studies done on a few of our vulnerable populations, and one of them has been done on people who are homeless. So UCLA screened individuals who are homeless to test a screening and brief intervention in a health clinic setting. And what they found that 11% were low or no risk, 42% were moderate risk, and 47% were rated as being dependent. So that indicates the need to think about substance use risk stratification, as Molly had just discussed. You may have more people in the yellow and red category than the general population, so we just have to be thoughtful about how we're going to approach that. So the example that I'm going to talk about is where our students conduct their clinical experience, and this is in a men's shelter. And this men's shelter has 150 bed capacity. It's open 24 hours, 365 days a year. It serves 3 meals a day. It has on-site medical and dental clinic. It has case management services and drug and alcohol treatment services. Those drug and alcohol treatment services include an intensive outpatient program, and also just general outpatient, and they're moving to also have a methadone clinic there once they are licensed. So it's been a great opportunity for students to experience this shelter. This has a wide range of shelters, and I realize that not all shelters that you may have in your community may have these range of services, but it has been really helpful for us, for the students, to see what we can link services to for these people that the students screen and then may have to do a brief intervention for. So as I mentioned, the students usually spend about 3 hours at their clinical experience, and as I said, they got a tour and an orientation, and then they implement SBIRT with another student from a different discipline. So one does the audit and the other does the DAST. But we also address tobacco use, and that's pretty significant in this population as well. So the other shelter that we're able to have students work in is a women's shelter, and these are sister shelters. They work together, and this one is 60 beds. It's open 24 hours, 365 days a year. It has 3 meals a day. They have case management, and they have a medical clinic as well. They don't have drug and alcohol services on site. So there's a few differences there. They are also, it's just a women's shelter. Children are not to be there. So what happens is that we schedule experiences for students, usually in the afternoons, because they have clinical experience. They have their classes in the mornings, and so it's difficult to get an interprofessional experience if it's not in the afternoon. So we try and schedule those in the afternoons, and students sign up for that. And so I wanted to share some of the benefits of our experiences and some of the challenges that we've done when we're implementing SBIRT within the homeless shelters. So the good news for us is that the staff has been trained in SBIRT thanks to our SBIRT trainer, and so they're very familiar with it. And when the students aren't there, they also do it during intake. This is because, in part, the men's shelter had received a HRSA grant to implement SBIRT at intake. As I mentioned, too, the men's shelter has an on-site drug and alcohol treatment, so when the students do the screening, and then if they do the brief intervention, they realize they need a referral to treatment, they're able to do a warm handoff to case management services for a referral to treatment, which is a huge help. Also, the fact that medical services are provided, too. We just had a situation where students had screened someone and they shared that they hadn't been to the doctor in over 3 years, and they used to be on blood pressure meds, and they had been getting headaches, and so we immediately got them an appointment with the medical clinic that day. What was really nice, too, is that we have office space provided to us, so they have a conference room for us to sit and interview patients and then talk about it afterwards. There are some challenges in that the men's shelter, where it's located, is a bit far for students, so they need to have a car to get there, so sometimes they have to Uber it or they have to get a ride from someone else. On fair weather days, clients decide they may not want to be in the shelter and they're off doing what they need to do, either trying to find a job or collecting their documentations that they need for various services that they need, or going to appointments. So that can be a challenge because we may not have enough clients to screen the day that we have students. And then sometimes we have other groups and activities that conflict with the time students are present. We try and work around those, but sometimes, like for example, in the women's shelter, they had a craft group one period of time right in the middle of our SBIRT clinic hours, and patients really did not want to come during that time. So trying to work around that and figuring out what's going to be the best time for everyone involves clients, instructors, and students is a bit of a challenge. So the next group of individuals who face some challenges I wanted to talk about was around food insecurity. So we know that approximately 13% of Americans are food insecure, and approximately 59% of food insecure households relied upon some nutrition assistance programs. Interestingly enough, there's been a study conducted that found that individuals who are food insecure are more likely to smoke, but there's been no difference among those who don't receive assistance in alcohol use. So their alcohol use is usually around the same as the general population. So that's thinking in regards to risk stratification, what your population may look like if you're going to be doing this in a food bank, which we did. So I want to talk to you a little bit about our food bank that we have. It provides approximately 23 million meals a year. It provides also emergency clothing, housing and rent assistance. They have a financial management service area, and where people who need a payee can be. Those people may not be able to handle their funds from Social Security, or maybe they have been they've been bankrupt before, and so they need help managing their money. They help sign up clients for public benefits and health care enrollment, and they have case management services and job training services. So it's a great service that they provide. So with us, with the food bank, what's been great about them is that they provide office space. Again, we have a conference room that we can do this, and that the administration is really invested in the program. The director of the food bank always comes to visit our students. Every time that they come to the clinical experience, if he's around, he just makes sure to introduce himself. We also have case management services where there is a nice warm handoff, so that's really helpful. But there's been some challenges, is that only some staff are trained in SBIRT, because as I stated on the other slide, there are just so many services that this agency provides that the staff just don't even know what SBIRT is or how to go about implementing that. So we've been trying to do more trainings with this agency. The other thing is that screening only seems to be implemented when our students are present. And so we're looking to implement it program-wide, but they have so many different entryways into the services that has been kind of a challenge, because some people may only come for to get emergency clothing. Some people may only come for food. So there's different things that people come in for, and so they may not necessarily be able to be screened. The other thing is clients may not disclose some of their information in regards to their substance use because of potential loss of services. So what we are looking to do is have a student intern there who will help infuse SBIRT into the agency in the fall. So our goal is for the students to take our SBIRT course and then figure out a way where they can implement it agency-wide. So we are very lucky to also be able to work with a federally qualified health center. And so those centers, they were first established in 1965 during Johnson's War on Poverty. And they're usually located in areas that are medically underserved. So they have high rates of individuals who are uninsured and who are on Medicaid. They provide high-quality, cost-effective health care, and they require 51% of the governing board to consist of consumers of the center. So there have been several studies with SBIRT in these health centers, and it has been found that when SBIRT is implemented in medical settings, that it can significantly improve from baseline to follow-up illicit drug use and heavy alcohol use. There also is, SBIRT has been conducted with adolescent participants. And so when this was done in Baltimore, 30% of adolescents reported using more than one substance within the last year. And there were rates of alcohol use, cannabis, and also illicit drug use besides cannabis, and also tobacco use. So our particular health center, it follows the philosophy of Christ Community Development, and they focus the 3 R's, which is relocation, reconciliation, and redistribution. They're really located in an area that has significant poverty levels, so this is very important to them. They have a range of clinics, and they provide more than 33,000 visits per year across 5 sites. The site that we go to also has a pediatric clinic, but we do not have students doing SBIRT in the pediatric clinic at the current time. And then they have 2 school-based health centers. So what's great about this health center is that it's been very supportive of student learning, and the SBIRT is in the electronic medical record. Actually, the medical assistants initially screen patients with the Audit C, and that's instead of students, which can kind of create a bit of a challenge because then the students don't get to actually screen the patients. They just may be able to do the brief intervention or the brief intervention referral to treatment. They have a social worker and a counselor on staff for a warm handoff of any of the referrals to treatment that they need. And what's been really nice is in Ohio, they have the state grant that provides money to healthcare centers for training allied health students in order to encourage these students to seek employment at graduation. They pay so much per hour for having a student. So as I mentioned, with the challenges, instead of students and staff providing the screening, medical assistants do that. Sometimes when patients aren't feeling well, they don't want to see the students. Sometimes we have issues with space. We have actually had to wait in the chapel area until the client is ready at times. And that goes along with the next point, which is sometimes staff don't remember that students were there to see the patients because we are located in the chapel area. And the other part of that is that students need to be aware of and be comfortable with the Christian-based mission that this particular health center focuses on. So we would like to now discuss some steps for considering implementation with SBIRT for vulnerable populations. So some things that you want to consider is identify your supporters. So who are these individuals who are trained in SBIRT or who would like to be trained? Those can really be your key allies. You want buy-in from the administration, the board of directors. As I mentioned with the Free Store Food Bank where our students serve, the administration there is very supportive of that. Actually, all the agencies that we work with are very supportive and engaged with SBIRT. If possible, if you could find clients and consumers who are supportive of the service, that would also be a benefit for you. You also want to think about the process. So when will this screening occur? Are you going to do it at intake? Are you going to do it with the doctor? How are you going to be explaining this to the patient? I mean, it's very important to talk about universal screening with the patient. Where will it occur? What's the physical space looking like? Is it in an office or is it in a conference room? That type of thing. Who will perform SBIRT? Is it going to be medical assistants or the intake staff? what measures are you going to be used? Are you going to use the audit or the DASH, or what about something specific for adolescents? You need to think about what's going to happen if a positive screening occurs. Who does the brief intervention? What staff? And how will this impact the person who has a positive screen? Will there be any benefits that they may lose if they have a positive screen? Most importantly for our population too is you want to think about referrals to use in the community if needed. So do you have services that can be provided in a different language if necessary? Are they only willing to talk with a particular person about their use? Maybe they're priest or minister or rabbi, any type of spiritual leader. They may not be interested in treatment. And the big thing for us and what we're dealing with is how will billing occur? So we are really trying to address this here in Ohio, and I know for other people it can be a challenge. So now I'm going to pass this over to my colleague Molly.
Thank you, Shauna. So on this slide, I identified some elements of what we have identified as vulnerability factors for the patients who come to the MAP clinic. I'm just going to take a few of them and show you how it applies to implementing SBIRT. So one of the second item says survival mode. So what we're saying is that because the basic needs are often not met in the patients because of their status, they typically are in survival mode when we see them. So when you're doing SBIRT and brief intervention and you want to schedule them to either come back for another session or even for a referral, very often that is compromised by being in a survival mode because other things tend to take priority. So one of the rules of thumb that we have developed at the clinic is that when you are looking at this client in front of you, try to do everything you can at that session because you may not see them again. You may not see them again. You may not see them for their next appointment. And it's not because they are resistant. It's just that the pressures of survival take precedence over other things. And so we have noted that in our population. The other issue I wanted to just mention here is the last one, fearful and anxious about immigration status. What that exemplifies is that vulnerability factors may change over time. So I'm sure you're all aware of the fact that probably within the last couple of months, there have been a lot of changes, and we have seen very high anxiety levels in the patients who are coming to the clinic. They're not sure what's going to happen to them, what's going to happen to their children. And if you think about when we do SBIRT screening, and obviously we would like to see truthful information as much as possible, but if you look at that from a backdrop of, I don't know who I can trust, I don't know what's going to happen to me, you can see that that might impact the accuracy of how individuals represent their substance use. In addition to that, it may be that the brief intervention actually gets focused more around those issues as they link to substance use. So you can see that vulnerability factors can change over time, and I think it's very important for us to be responsive to that and to understand that. I read some research which I find fascinating, which seem to suggest that for ethnic groups and other minority groups, the MI part, the motivational interviewing part of the brief intervention really helps to allay a lot of anxiety and fear in a population that is often disrespected, often faces discrimination, to be able to convey empathy and to convey respect in the way in which we implement motivational in SBIRT, interviewing in SBIRT, really does become important to these groups. And that has stuck in my mind, and I definitely want to think about how we could adapt SBIRT to ensure that it is a comfortable, a good experience for individuals who have a lot of concern and anxiety. So this is just a list of a number of ones that we've seen at the MAP clinic. But again, I wanted to just highlight how often they are related to how we implement SBIRT. Another way in which we look at this, we find from an interprofessional point of view, is that some professional disciplines have more difficulty with parts of SBIRT. There are some disciplines that have difficulty asking about substance use because it just feels uncomfortable to them. There are some disciplines who are fairly uncomfortable with the brief intervention using MI because it's just not consistent with the normal way in which they operate. But I think it's an opportunity for us to really think about how can we figure this out in ways that benefit our patients, so that if being more empathetic, if being a better listener by using techniques that ensure that the patient feels that they're being heard and understood can be a part of SBIRT, that makes it a more positive experience for the patient, and that's the thing that we have in common. In the MAP clinic, we are constantly rotating through students, and student training is ongoing. But I think that what we have learned is that we're beginning to understand how elements of the SBIRT process may be embraced or not embraced by various professional groups, and that in itself is very important. It means that we need to really focus more on how can we reach these groups, how can we find a place to validate more interprofessional collaboration, even in the implementation of SBIRT. So when we think about this patient profile, you can see all of these issues, and really a number of them will definitely can impact SBIRT implementation. Obviously, we've talked about some of them. I've given you examples there, but really all of them can have an impact on the implementation of SBIRT. One of the things that we've seen is that the referral to treatment. When you look at referral to treatment in SBIRT with a population that is an immigrant population or a refugee population that is undocumented, you can't just necessarily say, okay, why don't you go to this particular agency? What we find is that if you're engaged in case management to identify potential referrals for this group, you really have to think out of the box. In fact, you have to do a lot of creating resources, community resources, because a lot of the patients cannot just go to one of the regular community resources. So in order to implement SBIRT in a way which really does move that patient toward being able to get their needs met, we have to be more of an advocate in helping to ensure that there are resources for these individuals to be referred to. This slide just simply represents in a concrete way how the vulnerability factor is directly related to SBIRT. So when we look, for example, at culture, it makes a difference as to how we implement SBIRT. There is a particular clinic that serves a population where the members of that group are not supposed to drink or take drugs. So obviously, when you ask them about their substance use behaviors, you wouldn't be surprised to find out that they may not be very forthright in sharing that. But we have been able to think about alternative ways. Very often, people want to share that. It may not be culturally appropriate to do that. What can we do to make it easier for them to share their substance use behavior, and that is consistent with their cultural background? These are things that we need to think about all of the time. I gave you an example of, again, them not being eligible for services, also more females actually coming to the clinic, but the males actually having more of the risk for the substance use. So those are things we have to kind of think about, and they represent kind of the contextual environment in which SBIRT implementation occurs, that if we're really going to reach these populations, we kind of have to be innovative and to think about that. As I indicated earlier, there is research that shows that risky substance use varies by race and ethnicity. So we have to know these patterns, and we have to formulate ways to address them when we interact with these vulnerability factors. I did find some research that indicates that the audit is the most evaluated screening tool that works with multiple ethnic and racial groups. If you didn't see that, I found that very fascinating. Cultural adaptation of SBIRT is very important, and to some extent, this may be the area that we struggle the most with. We are all supposed to adhere to the class standards, but sometimes it's easier said than done. But this concept of cultural adaptation suggests that modifying and adapting of an evidence-based practice or protocol in a way that to make it more compatible with a client's cultural pattern and meanings and values is very important. And I think that this is an area where we think out of the box about how can we do this. We translate a form into Spanish, and then we realize that that's only one group, and then there are dialects within that group. How do we make sure that when we do screening and we use screening instruments, everyone kind of understands what we're trying to say? As you can see, it is a difficult issue. So even though it can be difficult, I think it is well worth it. It's something that we really need to spend the time thinking about, because it will allow us to be more effective with groups that represent cultural diversity. This term of acculturative stress is really important, because what the research seems to suggest is that acculturation, or the degree of acculturation, is very much related to substance use. So that to the degree that individuals are not as acculturated, meaning that they haven't necessarily adopted the patterns of our society, they are more likely to have lower substance use levels. To the degree that they acculturate with our kind of society, they tend to have higher substance use. That's an important kind of summary of research. What we do with that is very important. There are acculturation assessment instruments. Is that something that we might consider doing as a way to also gauge the risk for substance use? that is an example of how we really are needing to some extent, be innovative in the way in which we address some of these issues, keeping in mind fidelity too. So I'm just simply saying to you, fidelity is very important, but also the acculturation adaptation is also very important. I think I've kind of talked about this, and I shared that we were trying to figure out how to empower women so that they would take the educational information or the information on the guidelines on substance use home to have discussions within the context of their families. That represents kind of an example of how we can implement SBIRT and still consider the vulnerability factors. I think that as I'm looking at this, and I know we're getting close to the end of our time, I think I've pretty much talked about most of these, but you can see that to the degree that you have a group that has a higher risk for certain diseases, that will impact SBIRT and the ability to refer them and how those dynamics play into brief intervention. All of these are connected. So vulnerability has the potential to impact SBIRT, and this is where adaptation has a place. This is the research that I cited about motivational interviewing, perhaps more emphasis on that having a greater positive impact on ethnic groups. And also I want to call your attention to the CAMI, if you haven't heard of it. It's called the Culturally Adapted Motivational Interviewing tool, and it shows that it has a positive impact on diverse groups. These are the kinds of not only resources we might need to think about using, but also think about the kind of research that we do to further understand these connections. Again, another example, but I think I've talked about all of those as well. And so there is a place for us to consider the connection between the vulnerability factor and SBIRT. Obviously, we cannot address every vulnerability factor, but we need to think about which ones are most relevant and put our heads together in terms of really thinking out of the box about how can we impact the effectiveness of SBIRT through addressing some of these issues. This is a summary slide that shows you the elements of what we've talked about in this presentation. The importance of considering these factors as we look to create a vulnerability profile. And then lastly, what this slide shows is the vulnerability factors will impact SBIRT outcomes. And therefore, they become really important and relevant. Shauna will now summarize our session for today.
Thank you, Molly. So as we've really emphasized, interprofessional collaboration is really critical for clients who have multiple risk factors that Molly had talked about that faces them. So just with the complexity of what goes on with these individuals, we need a more holistic approach to impact positive outcomes. And we know that if providers work with vulnerable populations and think about how different things can work together, different resources, different ways to figure out what can we do for these people. We promote a strengths-based experience with them, and they have a shared understanding and can work with these vulnerable populations. Implementing SBIRT in an interprofessional setting can be challenging but very rewarding with better patient outcomes. We are all dealing with silos oftentimes with our educational system and our just practice system, which is not conducive to understanding the holistic needs of clients. And so another thing that I think Molly did a great job of emphasizing is that serving vulnerable populations will often require balancing, adapting to meet the needs of the cultural needs of the patient without compromising the fidelity of the evidence-based practice. So we'd both like to recognize and thank SAMHSA for providing support for our SBIRT grant. And we would also like to just note that there are references available for you to refer to if you have any questions or want further information. We are available. There's our email address, and we really thank you for taking the time out of your busy schedule to listen to this webinar. And I'm going to pass it over to Tracy. Thank you.
Well, thank you both. Thank you, Shauna. Thank you, Molly. That really just was terrific presentation. So thank you both. I personally am looking forward to listening to it again. And I've got a couple of notes sent to me saying they're looking forward to listening to it again. What a really rich presentation, lots of things to think about that many of us and many on the webinar today have been doing SBIRT for a while. Others are new to it. And I think anyone on this webinar could glean something different and new. And it gives us something to think about as we take the practice of SBIRT into just such a diverse array of settings, and also as trainers and educators about, you know, what do we incorporate into the education that we're providing to let us really think about a lot of the issues that you've brought forward that you don't often see. So personally, I have gotten a lot out of this, and I know I can tell others have too. You're really getting us to think differently, and I'm grateful for that. So thank you very much. And I want to open it up to questions. We're starting to get a couple of questions. I'll just remind folks that if you're not familiar with GoToWebinar, up in the right-hand side of your screen, generally you'll see the GoToWebinar panel. There's a questions pane. Go ahead and type your question in there, and I am going to take a look and see what questions have come in. So, as I mentioned, there are some folks who are very new to SBIRT, haven't implemented it, thinking about doing it. I think today you've given them even a lot more than even they probably even imagined coming to this. So the question, this is coming from an agency, a federally qualified health center. I think we have a number of folks from that setting who work with vulnerable populations joining us today. And the question is, they're thinking about integrating SBIRT into the practice within their FQHC. And the question is, do you believe in universal screening? And we're focusing on vulnerable populations, and that's sort of a specific direction. But how do you feel about universal screening? What are your thoughts on that?
I love the idea of universal screening because substance use has the potential to impact any problem or issue wherever it surfaces. It impacts health status, it impacts behavioral health status, it impacts families. We're getting ready to do a conference with behavioral health and first responders. It impacts disaster survivors. There's military. So the potential impact of substance use is so very broad that it is worth it to identify it early on if it can help. And I think SBIRT is a proven evidence-based practice that indicates that it can identify early substance use, and one of the most common responses I often hear from individuals as we screen them when they look at the charts and they understand their use is, I had no idea that my substance use would be considered risky. And so even that realization can be the first step in looking at, so what are you willing to do about it? It is so important. I love the idea of universal screening.
And I'm going to second that. Yeah, I'm going to second what Molly said. And the other part is when you do address it to people, the tagline is, this is a universal screening. We screen all our patients, so they do not feel targeted. And that's the buy-in. And as Molly highlighted, it is prevention. We're really working to educate people.
Well, thank you both for your response. I think that's echoing a very strong yes. I have another question. This is interesting. You're both educators and you're trainers. So how much training is necessary to do SBIRT appropriately?
SBIRT is a skill. And so we can teach the basics of SBIRT, but the way you develop skills is by practice. And so we've been creating opportunities for practice with students, so we teach them the basics, and then they have a limited opportunity to practice it. One of the things we're working on is working within the practicum clinical environment so that students have the ability to have more opportunity to practice it. So the more you practice it, the better you get at it. We've had some students who have just, they've done it so much, it's become like second nature to them. So it's always been very helpful to me to remember that it is a skill and you develop skills through practice.
Thank you. And then another question we have here, we've mentioned the audit. It's been translated into Spanish and been validated. Have any other language translation versions been validated? Have you used any of those yourself?
We have not, because our predominant population has been Spanish speakers. But we have really scurried around trying to think about how to reconcile that issue. And so interpreters help. We've had students sometimes volunteer to, translate into a particular language. But again, you get into dialects and those kinds of things. So it's not perfect. We need to really think that through. Many of our patient populations, their literacy level is very low in their own language. So we talked about how to figure out ways to communicate well, but it is a challenge. It is a challenge.
Yes, and I can just mention that there is a site, the World Health Organization has a site, and they're publicly available, and they're translated into a number of languages. I have French, Catalan, I think I have Japanese. I have several in my own collection, but I do know they have a site dedicated to it. I couldn't tell you all of them, but we could look up try to find the website and see if we can add that to the webinar page. That may help some of the folks who are looking for those various versions. So we are actually at the close of our webinar, and very generously, both Shauna and Molly have offered their email addresses, and if you have burning questions that we didn't get to ask, it sounds like they have put that forward, and you are welcome to email them if you have a burning question. So I appreciate everyone, their questions, and for being with us today. And I would like to, just in our last few moments, just thank both of you, Shauna and Molly, for such a rich webinar. So thank you so much for that.
Thank you.
In addition to that, I'll remind the attendees that all of the PowerPoint slides are available on the webinar page dedicated to this webinar on our hospitalsbirt.webs.com website. There you will also be able to request a certificate of completion, and you'll be able to request your continuing education credits. This webinar offers 1.5 NADAC CEs, and you will see a link to be able to fill out the form and request and claim those and to receive your certificate. The on-demand recording will also be posted on this webinar page as well. Once you've had a chance to watch the on-demand recording, you're also eligible to receive CEs, so we ask that you come back, complete the evaluation form before you request your CEs. And for those who are attending live today, you will see that there's a link posted for the evaluation survey. It's a very, very brief survey. So if you have a few minutes right after our webinar, if you could take a minute to complete that. It's really important in our maintaining our funding to be able to provide you with the kind of quality professional development we've been able to offer you today. So please, we do actually look at those, so please complete those. And you'll be receiving a follow-up email. It'll have a couple of reminders. It'll point you to where everything is on demand. And so I just want to, again, thank you, the presenters, and the attendees for joining us today, and all of the partners. Andrea, thank you for joining today, and thanks CSWE for your partnership on this. And again, you're welcome if you have any questions for me about SBIRT implementation, you're looking for some technical assistance, information about training, you are welcome to contact me as well. So thank you, everyone, and I hope you have a great day, and I hope you will look for more resources from us on our SBIRTeducation.com website, and we look forward to having you on future webinars.